like I said, we're just going to get started with intro stuff. So I'll just begin with introducing Step into Oxmed. Hopefully, you guys are a little bit familiar with us because, of course, you've signed up to this talk. Essentially, Step into Oxmed is just a group of medical students who are very, very passionate about widening access and participation to medicine. I myself am actually a former STEP student, so I really benefited from the resources that they were providing, and we hope to be able to do that for all of you guys as well. Just to introduce myself, my name is Nazifa, and I'm a first year medical student, of course, at the University of Oxford. I'm at Jesus College, and I'm also joined by my lovely co-host Amma, who pretty much just coordinates like everything we do at STEP. She's great, and she's a clinical yet medical student, so much more experienced than me. And yeah, so can we have microphones off, guys? Yeah, that's also something I need to mention. So just with regards to housekeeping, if everyone can keep the cameras and microphones off, that would be amazing. It's just for safeguarding and to avoid disruption and things like that. Also, this talk is being recorded. So if you guys want to refer back to this at any point later on, you are free to do that. Finally, we will be having a Q&A session at the end, so you are more than welcome to put in your questions into the Q&A function. Yeah, fabulous. Also, like I mentioned, I am joined by Amma, who will be moderating and just making sure that everything's going smoothly. She'll also be putting in any relevant information that you guys might need into the chat, so do keep an eye out on that. Fabulous. Okay, so now just to introduce our wonderful speaker today. So we have Dr. Jack. I do recognize you, Dr. Jack. He has given lectures to us first years, and he was great at that. So I'm sure he will be delivering very well to you guys as well. So Dr. Jack is a medical doctor who splits his time between working in general practice and also being a lecturer at Pembroke College, which is a college at Oxford. He also works to promote equity, diversity, and inclusion within the medical school, and we're really happy and excited to have him with us today.
Great. Thank you so much for having me, Nazifa. And Nazifa and Amma, I might ask for some general little bits of involvement just to make sure it's just not me talking the whole time. Sure. But the questions are not meant to be like really difficult, but equally they might be challenging more for you, Nazifa, if you've not done clinical yet. Okay. So there's no problem. And also just to everyone, just to say, my toddler is being like bathed in the room next door to this. So if you hear any screaming or anything like that, it's probably just her, and forgive me for that. So yeah, thank you so much for the introduction. My name's Jack. I go by he or they pronouns, and I am going to give you a talk today, which I will start sharing my screen and bring up. Great. And Nazifa, can you just confirm that you can see my shared screen?
Yep, I can see it.
Wonderful. Fantastic. So the plan for today's talk is roughly about 45 minutes with some time for some questions at the end. I'm going to talk about how to take a history, and I'm also going to talk about physical examination. We're also going to maybe do a slightly exciting medical kit quiz. So this is us all having a really amazing time around that. There might be a clinical case, but I do want to have everyone have time to ask questions that we can go over at the end. So we'll see what we're like for time. One thing I want to really encourage everyone here, all you folks to do is to pause and try writing answers if I ask you to. So if I ask you to think of, a piece of medical kit, then it's really good for you to try and do that. And that's partly because we know that in educational theory, so people who've done trials on the way people learn, if you commit to an answer, whether you get it right or wrong, you learn it better. So it's to avoid this kind of thing, which a lot of people take as an approach. I'm sure I took it as a student, but it's very tempting not to try answering things. But even just, I won't pick on anyone to actually do it, but just for yourself, you can throw it away after, just try and commit to an answer if I ask a question. And then content warning, I think that this has already been shared by Step, but just to say that there's no overtly famously challenging material here, but equally we're talking about medical issues, and so stuff might come up. Everyone has individual experiences, everyone has challenging stuff that they face in their personal lives, and so if any kind of topic comes up that you find is particularly difficult for you, Obviously, it's not a big deal. There's so many of you, it won't matter, but do feel free to take some time, step back. This is being recorded. You can watch it in your own time. And if anything's particularly really, really troubling you, then obviously you can get in contact with us at STEP and the team can pass it on to me if they're not able to answer those questions. Great. So we're going to start with taking a history. And this is talking about taking a history of presenting complaint, HPC, from someone with pain. And the reason I put that in quotations marks is because a lot of medicine has this slightly troubling history. So the first thing we learn in terms of taking a history is how to take this history of presenting complaint. So even in the name, we've got this thing where we learn, oh, the patient's complaining. The patient's complaining of chest pain, the patient's complaining of dizziness, which is obviously not ideal as terminology. It is tradition, and I don't think it's a massive deal, but personally, I prefer to say taking a history of a presentation. But we're talking about history of presenting person with pain. And when we do this, we use a mnemonic, and the mnemonic we use is Socrates, which is why we have this picture, this ancient Greek philosopher, Socrates, who apparently was incredibly buff. But a mnemonic, for those who don't know, is kind of memory tool. So you have lots of different letters that make up a word, and each of those letters stands for a different word. So it's just a way of remembering causes of a problem or a way to do something. And in terms of the history of someone's problem, and particularly with pain, we're talking about the site. So Socrates S, site. So where is the pain? Seems fairly obvious start. Onset, when did it start? Obviously something that's happened just over the last few days and come on very suddenly is a very different group of conditions than something that's been going on for years. So that's helpful for diagnosis. The character, when we say character, we're talking about what type of pain. So is it burning? Is it stabbing? Is it shooting? That kind of thing. Radiation, this means does it move anywhere? So there's a lot of cross wiring in the body in terms of the nervous system, in terms of the pain receptors. So a lot of internal organs actually share some of their roots back to the brain through other bits of the body in terms of the skin and the muscles and stuff. So a lot of the time you'll find you have a pain from an internal source and you're also getting some pain externally. And the famous one for this is things like a heart attack. Sometimes people get jaw pain or arm pain, but also things like the diaphragm, which is the muscle that runs underneath your lungs and helps you breathe. If you have a problem there, sometimes you get a problem in your shoulder tip. And so these kind of things can give us clues as to what might be going on inside someone. Associated symptoms. So this is, is someone having fevers or vomiting or diarrhea? If they had all of those things with tummy pain, I'd think this sounds like an infection. Whereas if they had tummy pain without those things, I'd go less likely to be infection. It's not a perfect system, but it's just what other things are going on alongside, the problem they're having. Are they having palpitations, shortness of breath? All of these fall under associated symptoms. Timing, so different to onset. Onset is when it started. Timing, does it change during the day? So does it come and go all the time? Is it there all the time in the background and comes on, or it goes away completely? For example, people with rheumatoid arthritis, which is a condition in the small joints of the hands, although it can affect any joint, but famously the hands, they tend to talk about morning stiffness. So stiffness and pain in their joints of their hands that last for more than half an hour after waking and less than 2 hours. That's a really specific type of thing. So the timing can sometimes give us specific clues. Exacerbating or alleviating factors, again, it's just sort of to wedge it into this Socrates mnemonic, but it's things like, is it worse when you press on the area? Is it worse after eating? So there's a condition called gallstones, which you don't need to know about, but that's famously worse pain half an hour to a few hours after eating, because it's to do with the gallbladder, and the gallbladder releases chemicals to help you digest fats. So if you have a fatty meal, that happens and you get more pain. And then severity. And severity often gets thrown in at the end, and it arbitrarily say, on a scale of 1 to 10, 10 being the worst pain you could possibly imagine, 1 being 0 pain or not very much pain, where do you fall? And that is helpful in a way, but it's not helpful in an objective scale. So someone's 7 for some, one person is not the same as a 7 for another. But for me, this can be a really useful thing, because how severe is it affecting someone? So if someone's saying they're not able, it's getting in the way of their day-to-day, but it's not so bad, that's one severity. If someone says, I literally cannot get out of bed, I'm incapacitated, I can't go to work, especially if they're self-employed and therefore maybe they're very tight with their budget and they can't go to work, that's a huge problem in that person's overall life. And so it's a useful way of personalizing the pain to that person. How severe is it, I think, is much more useful than how bad is it on a scale of 1 to 10. Okay, so what else is in the history and why? I think I might ask Nazifa and Amar to step in here. So what other parts do either of you know can be in a past medical history? Or I've given away one there, but
Yeah, you gave one away. So yeah, past medical history, it's important to know the context from which your patient's coming from. So if they say that they have pain in their right upper quadrant and that's something they've had before and it's diagnosed, that will kind of guide you to what it may or may not be or what's more likely.
fantastic. What other things are involved in a history that we know?
Yeah, and I mean, I'm really inexperienced compared to both of you, so bear with me, guys. But I'm pretty sure things like social and family history as well. So just
Very good.
sort of taking into account the occupation of the person, because that might be, having a big impact on whatever it is that they're presenting with, and whether someone else within their family has also experienced something similar.
Brilliant, excellent, fantastic. So we'll go through some of those, but those are exactly the kind of things. So past medical history, and we have to learn a whole new language with medicine. So you're seeing this thing, we talk about angina or cardiomyopathy or congenital heart disease, all these kind of things. Family history, this has nothing to do with family history. It was just this really tickled me in terms of like the way families interact. You don't have a family history of being a clown, but just family history, something run in the family. Medication, which we'll talk about in a second, and social history, which we mentioned as well. So in terms of why we ask each of these things, the past medical history, past problems predict future problems. So exactly as we said, the right upper quadrant, have you had a problem there before? If you're having it again, well, it might just be the exact same thing. Obviously, you need to keep in mind it might not be, but it's helpful. But also things like certain conditions like high blood pressure or hypertension is a risk factor for things like heart attacks and strokes. So if one of you all came to me and you'd never had any problems in the past with your heart and you had chest pain, I would be much less worried about you than someone who's had 30 years of high blood pressure or diabetes or anything I know is linked to heart attacks and strokes that they've had for 30 years. Those people are much more likely to have chest pain that's related to a heart attack type problem. So the past medical history really, really helpful in terms of helping us classify as something at more risk or less risk. Family history, obviously there's a predisposition to certain conditions, and you can have things like a single gene problem, so things like Huntington disease or cystic fibrosis, genetic conditions you might have heard of where one gene just needs to have something go wrong and you get the condition, but also what we call polygenic, as in lots of genes are involved. So things like diabetes and heart disease, those have a lot of genes that are very, very complex, but very tightly kept within families. So really, really interestingly, type 2 diabetes, which we think about and is talked about as being to do with blood sugar problems related to what we eat and exercise state and being very environmental. But actually they did studies on identical twins separated at birth, and there's something like I'm not got the exact number, but my memory is if one gets diagnosed, then within 15 years, 96% of those people will also have type 2 diabetes. So incredibly tightly genetically linked. But then also it's not all genetics. If your family has lived and lives and has always lived in an area with high air pollution, well, guess what? You're more likely to get lung conditions. So there can be a family history that can be helpful, but not necessarily related to genetics. So useful to keep that in mind. In terms of medications, it tells us the past medical history, PMH, as we talked about before. So I can look at someone's medications with the years of training we have and go, okay, they're on lots of blood pressure medication. And if someone's on a very small dose of one blood pressure medication, they are much less likely to have problems from their blood pressure, heart attacks and strokes, than someone who's on maximum doses of 3 or 4 medications, because they've had to come back to me over and over and over and get higher and higher doses. So medical history, very useful in that sense. And also because medicines can cause literally every symptom, any single symptom that you could present to a doctor with, a medicine could cause that. And so I'm always looking at people's medicines going like, oh, could you be the culprit going on? Not always the case, but useful. And social history, as was alluded to earlier, we talk about social history as being things like smoking, drinking, recreational drugs, but also absolutely what's the home life like, what's the work life, and what's the impact on that person as an individual. So that's why we ask all those things. Okay, let's talk about what's been left unsaid. So again, Nazifa and Amar, if you could chip in, what might this person clutching their chest, what might they be worried about? Why might they come and see me as their GP? What might they be worried about?
Well, I'd imagine that now, given the rise of the age of technology and things like that, it's very easy for patients to just Google a symptom, and we just take Google as being Dr. Google, and I'm having chest pain, and Google tells you, well, you are predisposed to every kind of I don't know, heart attack or whatever, and patients can become quite worried about things like that. So they sort of come in with an idea before even presenting to you, and that might be the thing that is sort of exacerbating their initial worries.
Yeah, true. And personally, I have absolutely no problem with people Googling stuff. I think it's the most natural thing in the world. And actually, just as a behind the scenes thing, when I'm dealing with someone in front of me, a lot of the time I will ask them, have you Googled anything? Just to give them the permission to go. Like, some people go, oh no, I'd never do that. But sometimes patients feel as though they might be undermining us by Googling. And for me, I just want to get on the same same page as someone, work out what they might be thinking. Amal, have you come across a acronym, sorry, a mnemonic or an acronym here that might be helpful for us in terms of what might not be said in a consultation?
I have indeed. The acronym is ICE,
Fantastic.
ideas, concerns, expectations. So those are things that are important to remember to ask a patient about. Like everyone's been saying just now, they might have their own ideas about what's happening or be concerned about something in particular. And then expectations, it's kind of like they've come to you for a reason. So it's kind of like, what would they like to get out of the consultation?
Yeah, absolutely. Fantastic. So expectations is another one of it fits the mnemonic, but we have to be a little bit careful. It's a bit like complaining. Oh, what's your expectation? What do you want here? And that's not what we're trying to get at. We're trying to get on the same page to make a plan together with the person. So some people might come to me with chest pain and they might be worried about cardiac, heart problems, and they might think, I just want you to tell, the ideas and concerns is ideas what they think the most likely thing is. Concerns, what are they really just wanting to rule out, just wanting to be absolutely kept sure, and that might be the same as ideas or it might be different. And expectations is sort of why are they coming to me? Is it just to go, the doctor saw me, listened to my heart and said I was fine, great, I'll go home and have a good night's sleep? Or do they think maybe I need a blood test, maybe I need a tracing of my heart, in which case it's really good to get on the same page so I know I can either say, yeah, I think those are perfectly reasonable, or a cardiac MRI for your chest pain that's been going on for a day, that's going to be quite difficult to convince the cardiologist to do. So just not in a bad way. They don't need to, they're not supposed to know that, but making sure we're on the same page. And why is it medically important? Well, this we've mentioned heart, and I think people always worry about their heart for the last several decades. But this person, with their chest pain, if I jump to it being their heart, and I go, oh, Marge, Marge, don't worry, I've listened to your heart and I've done an electrical tracing and everything's fine. You've got the heart of a 20-year-old, off you go. And I go, well done, Jack, what a great doctor you are. Well, if Marge's uncle died of esophageal cancer and the first presenting symptom was chest pain, well, maybe that's what they've been worried about for weeks and weeks and weeks. And if I don't get on the same page as someone, I can't actually help them. I might rule out heart problems, in which case I might think, oh, as the doctor, I've done my doctor bit. But unless I'm actually talking to that person about why they don't have esophageal cancer, I might think it's really obvious, but I need to go, right, I think you don't have esophageal cancer because of this. You're too young, you're not having swallowing problems, you're not losing weight, all these things. Unless I actively address that, I'm not helping that person, I'm just seeing them. So ICE is a really, really profoundly important part of any medical consultation. I tend to start after the initial how can I help you and letting someone talk about the bit of the background. I tend to start almost every medical consultation I have with it, so I'm on the same page as someone. Fine. What else helps us make diagnoses apart from the history, which does most of the work for us? Physical examination. So this tends to be what's called system specific, just so you've heard that word. So cardiovascular system, the heart and blood vessels, the respiratory system, the lungs, the gastroenterological system, which is everything from your mouth to your anus. 4 key principles of physical examination: inspection, which is having a really good look; palpation, which is having a feel either of the tummy or somewhere else potentially; percussion, which is demonstrated in this technique where you're basically holding your finger down on the area and then tapping the finger. So I'm going to do it on my desk. That sound that is made gives us a clue as to what's underneath the finger that's pressing down. So particularly in the chest, you could have, air in there, so it's resonant. It sounds like a drum, like boom, boom, boom. Or it could be full of fluid and it's very dull and it doesn't make a resonant sound. So these kind of things can give you clues as to what might be going on inside someone. And then auscultation, which is a fancy way of saying listening. So I love stock photos. Generally, I just think they're really funny because they're always really staged. But this one in particular really tickled me because it looks as though this doctor is listening to a sort of younger clone of themselves, which I just found really, really tickled me. Specific kit for examining. So I'm going to give you 30 seconds just so I'm not talking the whole time. I want you to just think of any, stethoscope is one, right? So things that doctors use to help them examine people, help them make diagnoses. I'm just going to give you 30 seconds to take a quick second, maybe grab a drink if you want, and think about any kit for examining. So start the clock now. Okay, great. It's not quite 30 seconds, but you've got plenty of time. So we'll come back to that a little bit later. How exciting. Right, inspection. So fortunately, we do have some medical students, which I wasn't entirely 100% sure, but inspection. We're going to go through some of this, Nazifa and Amar, and if you can just tell me, what can you tell in each of these areas about the person and about sort of medical issues? So this one's pretty obvious. So for the example that I'm going to give is a huge part of medicine is us teaching you to notice and register and analyze what you're seeing. So this person is in pain, right? A lot of people would just be able to say that, but why are they in pain? How do you break that down into its component parts? So they're grimacing a little bit, they're holding their chest, they're leaning over. Those are the kind of things you start to learn to just say out loud so that you conceptualize them, and it helps you really pick them up in more subtle situations. So Nazifa or Amar, if you can just tell me what you're seeing here.
So here, looking at a patient who is severely underweight, to the point where it's some kind of muscle wasting, and you can see their kind of ribs underneath their skin.
Absolutely.
Yeah.
Fantastic, absolutely. So and muscle wasting is a really good thing to have picked up here. So fancy medical terms that you'll hear thrown around for this would be cachexia, which is kind of like wasting, and then specifically muscle bulk being reduced is called sarcopenia. You don't need to know why them, but it's just to get you a feel of what we say in medicine. But the important thing is we need fuel for our body, right? And especially in chronic diseases, and by chronic I mean long term, not necessarily serious, but long term, but they can be serious. So things like serious lung disease, serious heart disease, serious kidney disease, serious liver disease, cancers. A lot of the time you're having a huge energy demand on the body, and sometimes you just can't take in enough energy to rectify that, and sometimes your appetite is actually suppressed by the long-term sickness. And the body obviously uses carbohydrates in the short term, then it uses fats as well. But if you're using up all that fuel, what's left as a fuel? Muscle. So what you'll find is people can get this kind of wasting when they have a long-term serious disease. So if I saw this person, that's the kind of thing I'm thinking about in the background. What differences can you, Nazifa, what differences can you see here between these two scars? And you can be as obvious as you like.
I'll be very obvious. The one on the left is a lot longer.
Yeah, absolutely. So it's a lot longer. I agree. And anything else you can see?
One on the right is a lot darker as well.
Yeah. And what do you think about the darkness? What might that be representing?
I was to guess with my little first year mind, maybe it's because that's dried blood that's just come together. So it's just sort of like a scab that's formed there.
Yeah, absolutely. And what does that mean about the age of the surgeries in these two? How long ago did the surgeries happen in these two?
The one on the right would have been a lot more recent.
Perfect, exactly. So why is this important for me if someone came to me with chest pain? Well, if the person with the scar on the right came to me with chest pain, I'd think, uh-oh, this person might be having a complication from their obvious, central chest, probably heart surgery. Whereas the person on the left, if they came to me with chest pain, that scar is 20 years ago. I'm thinking incredibly unlikely to be to do with their heart surgery. Not impossible, but that's part of how we're using inspection to help us with our diagnosing. I mean, with that one, even I'd hope with the eye of faith I could sort of convince you that actually you can see the sort of square dressing that's previously been there, and actually it's freshly shaved. So that's incredible. That's literally a couple of days old probably that surgery has happened. So yeah, brilliant. Nazifa, this might be, I wouldn't expect you to get this. This is more sort of finals or like, F1, F2. But what can you think of anything why you might have sort of these little black dots in the side of someone's fingers?
I imagine it's some kind of internal bleeding. I wouldn't really be able to imagine why that might be. Maybe some kind of blunt trauma.
Good thinking. So it is little bits of blood. Amar, can you think of anything just moving obviously with your clinical experience. And then again, I really wouldn't be expecting you to get this quite yet, but if you did, it's fantastic. But talk me through what you might think might be going on with these little tiny bruises.
I'm not sure, I've not seen it before, but maybe the fact that they have bruises, if someone bruises easily, that could suggest something about how the blood inside of them is clotting, maybe.
That is very true. That is very true. And I certainly would think that that would be a thing to be thinking about. But this is a bit of a trick one where you've either heard it or you haven't. And perfectly now, for both of you, if you're on ward rounds and you get asked this, you'll know it, which is great. This is basically someone who probably has diabetes and they're testing their blood sugar for insulin. So almost no other reason to have this. When people have insulin or some other condition to do with their blood sugar, but let's think about diabetes on insulin, they have to test their blood sugar regularly and they have to take small blood samples. And instead of, they do it from their fingers, but you don't do it from the fingertips and the pulps of the fingers, because obviously then you'd have loads of little bruises and it becomes very painful, so you can't really use your fingers. What you use is the side of your fingers. So these is someone, you know, every single day, 3 times a day, taking a sample of their blood to go, what's my blood sugar looking like? So if you see that in a personal inspection, without knowing anything else about them, you could probably go, well, they've probably got diabetes and they're needing insulin. What about this one? If we go, Emma, does this gait, so a gait is the way someone walks. Can you see anything here that you would, either you could tell me a condition you think of, or if you can just describe the gait for me using any kind of words?
Yep, so you can see that the patient is kind of stooped over as they're walking rather than standing up straight, and they're kind of shuffling their feet rather than kind of lifting their feet as you'd expect someone to walk. So also if you look at their arms, they're not really, when people walk, they tend to swing their arms, but this person isn't swinging their arms. So if I had to guess, I'd say it's characteristic of Parkinson's.
Wonderful.
I hope
that's
that's right,
really,
just...
yeah, no, that's perfect. And that's a really good, and you can see, you know, other people, you know, all of us before medical training, we can go, yeah, something's wrong here. But it's that ability to go small steps, shuffling, not lifting the foot up, you know, reduced arm swing if you want to really fancy, you know, make it fancy. Although the only thing I'd say, Emma, is this tendency that we all have in medicine to go, oh, the patient. It's sort of medicalizing people. This is actually not a patient. This is a neurologist who mimics gaits. It's a really, really helpful video that he puts on online. He does all sorts of gaits, but it's just like an interesting point to reflect on. But a phenomenal and absolute. This is a gait which is very, very typical of Parkinson's disease, which is a neurological condition. So this is, you know, you see it once someone walks into clinic like this, and you can probably go, this is incredibly likely to be Parkinson's. This is just for the sake of not taking too long and pulling teeth, this is a tremor. So I probably call it a fine tremor, which sort of people doing this rather than like a big flapping tremor. And this could be because of, excuse me, a thyroid problem, which is a gland in your neck that controls your metabolism. And if it gets very overactive, you can get a tremor. It could be because of an adrenaline, so you could have this tremor just because someone had a really bad fight. Maybe they'd just been in a fight or been mugged. It could be a side effect of a medication, so in asthma inhalers, something called salbutamol, if you have too much of it, it can give you a tremor. So we've got something going on, but it's not quite the same as the Parkinson's gait, where we're really keen on going, this is probably the diagnosis. This is a general thing that it's leading us down some pathways. And then this just finally is sort of yellowing of the eye, what would be called jaundice. And this is because in liver disease, there's a chemical called bilirubin, which the liver normally breaks down. And if it builds up too much because the liver's not doing its job properly, then it can accumulate in the eye and in the skin. And bilirubin is yellow, so you get this yellowing of the sclera and eventually the skin later on. So those are the kind of things you can see on inspection, which straight away can help you with diagnosing someone. Palpation, what might we feel in the abdomen? We might, so if this is sort of this is a CT scan, which is just a type of radiation scan. This person, if I can convince you, this is front on. So these are the person's hips. If you touched the front of your hip bones, these are their hip bones. This is their liver here. This is a blood vessel that supplies the liver. This is the colon. This is lots of blood vessels into the colon. This is their bladder. And these are their lungs at the top here. So if I said this is a completely normal CT scan, and this is the size of their liver, this is the liver of someone who has a very enlarged liver. And you can see how with this person, actually the ribs sort of, you can't see it, but if you can trust me, the liver is basically covered by the ribs, so you wouldn't be able to feel the liver. But this person, the liver will be poking out, so you'd actually feel the liver when you feel their abdomen. That's called organomegaly, so organ bigness, organomegaly, and that's something you might feel in the abdomen. This is something called ascites, which is a fluid accumulation in the abdomen. This happens as a result of certain organ failures, so heart failure, kidney failure, liver failure. You can have an abnormality in the way you're getting rid of fluid from your system, so you can have it building up in the tummy, so that's a lot of fluid. You can have air being trapped. This is a diagram from of the colon, so the large intestine, which runs around the outside and down into the rectum. And this can, in a specific condition called ulcerative colitis, you can have this getting blocked up and incredibly dilated, i.e. stretched. And this is a condition called toxic megacolon, which is a massive emergency, and people tend to have their colon removed. So you might feel solid, you might feel liquid, you might feel gas. And then this one, this is a bit of a trick question, but what would be, Amal or Nazifa, if we said, given that it's a trick question, what might people think this was in someone's tummy?
Well, I have two thoughts. A bit that sticks out, or maybe like a tumor.
Very nice. Okay, yeah.
That's what I would think.
No, I like it. So this is actually a normal phenomenon. So basically, this happens. Often people think it might be some kind of hernia, so sort of the bowel popping out through a weakness in the muscle. But if you think about where someone's abs run, you've got, if you thought about someone having sort of 6 or 8 pack, you've got a run of abs here, and this middle bit, the center bit, the thin bit of fibrous tissue between your abdominal muscles, can become very, very weak as we get older. People without much core strength can actually have that getting very stretchy, and it flares up like this. If you want to try and Google divarication of the recti, then you can see lots of pictures of it. It happens a lot in pregnancy, but it happens a lot as people get older, but it can often be misdiagnosed as a hernia. So these are kind of things you might feel in the abdomen. In terms of both percussion and auscultation, if you think about what kind of matter we might think, and in the lungs to disrupt sounds, we sort of touched on this before, solid, liquid, gas. So this is a normal chest x-ray or chest radiograph. So if I try and orientate you a little bit, this is the heart here. It's a little bit more to the left than the right, which is why it bulges out. This is just some lymph nodes and blood vessels, so it looks like a little bit of a white shadow. And in x-rays, black is air. So the lungs are generally black. You can sort of see them filled with air compared to, say, the bones, which are the opposite of white. So they stop the x-rays, whereas air lets the x-rays come through and therefore they go black. There's a little bubble in the stomach. These are the diaphragm either side. So this is a normal x-ray. If we think about this is here. I mean, these are breasts, which sort of cloud the picture. But if you see this area here, I'd hope if you compared it to this right side lung, this is sort of non-specific grayness, and that's often heard as that's a pneumonia. So it's what's called consolidation on an x-ray, and you hear it kind of as a solid / a liquid. It's a sort of muck and gunk. So when we're tapping, when we do the percussion, it can sound dull because you're not getting that air there to resonate the sound. Or you might listen with auscultation, your stethoscope, and you might hear crackles as air passes through this gunk and muck, and it makes a crackling sound. This is a liquid, so we've got solid, liquid, and this, if I can give it, obviously quite an obvious problem, hopefully you can see that, but if I can say this sort of line, this curved line that runs here and runs here, I'd hope I could convince you that was a curved line, and therefore it's what's called a meniscus, which is like a fluid level. So fluid can actually get trapped, not in the lung itself. The lung doesn't fill up, but there's a little space next to the lungs called the pleural space. It's where the lungs are next to the chest wall, and that can fill with fluid. So this is called a pleural effusion, which is just a fancy way of saying fluid in that area. And that you're not going to really hear anything when you listen there on auscultation, and when you percuss it, it's very, very dull. This one is probably the most subtle and tricky. I probably not expect people to necessarily be picking anything up here, but what I'd hope, if I could look at the normal x-ray, you can see all these tiny white lines. These are all blood vessels, so they're filled with small amounts of fluid, so they don't let the x-rays through, so they look white or grey. If you look at this side of the chest, you've got all those little white lines, which are all nicely there, and there's none here. And so what this is actually something called a pneumothorax. So pneumo meaning air, thorax meaning chest, air just in this space. So the lung is probably a little bit here and a little bit here. It's just been completely condensed down because you've got air trapped in this area, and so that will sound incredibly resonant when we're tapping on it, more so than on the other side, and you'll hear very few sort of air sounds being breathe through. So these are x-rays, but this is sort of showing you the kind of things you could pick up on examination. And then finally, for examination, auscultation. So again, remember, just listening. Really quick anatomy lesson for those who haven't sort of seen a picture of the heart before in terms of anatomy class. So this is just to show the valves, which I'm going to show you a little GIF in a second, which shows blood moving through the valves. But this tube here is coming from the lungs. This is the left atrium, and this is the left ventricle, and the blood comes through into the left atrium, down into the mitral valve. The valve is a one-way system, so it stops things going backwards. And then you have it going down into the left ventricle, and this very muscular left ventricle has all the power in it to push it out the aortic valve into the aorta and round to the body as oxygenated blood having come back from the lungs getting oxygenated. On the other side, you're getting this big vein, and this big vein, the superior and inferior vena cava, they're the big veins. And then you've got the right atrium, which takes in all the deoxygenated blood from the body, comes through the tricuspid valve, can't get any backflow because it's a valve, and it goes through the pulmonary valve out to the lungs to be oxygenated. And if we look at this one, so first of all, don't worry about this side, the left ventricle, the right hand side of the picture. If you look at this side, so deoxygenated blue blood coming through from the rest of the body, coming in through the vena cava into this side, the right atrium, down into the right ventricle, and then out all in the same direction, nothing going backwards, all going to the lungs. If you look at this side, you've got some red blood, all oxygenated, coming back, and some going out through the aorta as it should be. But look at this side as well. This mitral valve, there's a problem with it. And if you have some of this blood going backwards through the mitral valve, that's abnormal. So you've got what we call regurgitation, i.e. it's going backwards the way it shouldn't go, and so it's called mitral regurgitation, and this will have a really specific sound. The blood that moves through normally doesn't make a sound, it's soundless, whereas if you're going backwards, this circular line, spiral line here is to represent the fact that this will have what's called turbulent flow, which just means it's liquid flow in the wrong direction or in an abnormal way, and that will make a really specific sound. So this is called a heart murmur, and when we're listening to people's heart, we're listening for a really particular pattern to the sounds that help us go, oh, there's a problem with the mitral valve, or there's a problem with the aortic valve. And so that's another way that auscultation can help us. Ultimately, we're going to do an echocardiogram, a jelly scan of the heart to help really look at those valves, but it's still useful information for us to be able to pick up. Okay, so we talked before, I asked you to think about bits of kit that you might use. So Nazifa and Amar, I'm going to ask you to step up. So we're going to go through what is this thing used for. So stethoscope, obviously used for auscultation. What's this?
It's a lolly stick.
It is, and what's it used for?
I feel like it's put in patients' mouths.
Yeah,
I feel
absolutely.
like I can imagine that, but I'm not sure why.
Okay, absolutely fine, no problem. So it's a lolly stick or a tongue depressor. So the clue is in the name. It's to help us look at people's tonsils. So a lot of the time when you're trying to look at someone's tonsils to diagnose tonsillitis, maybe white spots, bacterial pus, you might get them to say but sometimes that won't do the job, and you have to use it to dampen down their tongue so you can get a good look at their tonsils. What about this one?
And that's like the little like hammer thing that's used to test for reflexes.
Excellent, perfect. So a reflex hammer or a tendon hammer. So this is looking at the central nervous system. If people have very big reflexes when you tap them, that can be a sign of certain types of problems like strokes, or if they have very little reflexes, it can be other types of problems. This one.
I actually don't remember what that's called, but it's tuning fork, yeah. Fantastic. What you use it for is to kind of test the patient's hearing. So you kind of hit it against the surface and it makes a ding sound, and then you can test it in different ways.
Very good. Yes, it's to test people's hearing. It's partly you can hold it to the side, to their bones, and also in front of their ear, and you're looking for whether they've got a problem in the canal or whether it's a problem with the nerve itself. So very good. What about this?
That's a lubricating gel that can be used for different things. So if you're doing an examination of someone internally, so if you're putting your hands or any instruments into maybe their anus or something, you would lubricate it. Or if you're doing an ultrasound, which is a kind of imaging you can do, you put it on the end of your probe so that you can put it on the patient and then look at their kind of organs and stuff.
Fantastic. Yes. So I would say generally, just as a word of warning, if you want to be a doctor, you're going to have your finger in a lot of people's bottoms. So if that really turns you off, I really wouldn't do medicine, because as a GP, I must do it 2 or 3 times a day, feeling people's prostates, feeling people's, anuses, maybe doing examination of the vagina, maybe with a speculum. So all sorts of different types of things that you'll need to just get used to. But the lubricating gel is a very nice way of making that not comfortable, but less uncomfortable for people. This one does have a little bit of writing on which might help you.
I think I actually have one of these at home.
Great. Yeah.
Yeah, it was given to me as like part of a little aspiring medics workshop thingy. I think it's like a little light that you shine in someone's eye, and it can be used to detect like how much their eye is like dilating or constricting based on how much light is shone at it.
Fantastic. So it's a normal reflex for the pupil to constrict when light is shone on it and to dilate when it's not shone on it. So this is a pen torch or an eye torch, and you just look at different pupils and you move the light in and out, and while you're watching, you see the pupils constrict or not. These ones are tricky. Can you tell me any of them? If we say this one is the left, middle, and right, can you tell me any of those, what they do, and then we'll put everyone out of their misery.
I think the left one is used for checking temperature. So you put it in someone's ear.
It looks like that. You do put it in someone's ear, but it's not for checking temperature.
Oh, okay.
It's an otoscope, so it's to look in someone's ear canal. But very good. It is absolutely the ear. What about the middle one or the?
The middle one is an ophthalmoscope. So
Brilliant.
that's basically a kind of magnifying glass for the eye. So it shines light into someone's eye, and then you can see kind of into the back of it and see the vessels and stuff. They're
Very
really
good.
hard to use.
They are incredibly hard to use, absolutely. But an ophthalmoscope, so ophthalmology, the eye sort of, part scope, camera or lens, so ophthalmoscope. And the other one, which I wouldn't expect anyone to know, is a dermatoscope. So it's to have a really special magnifying glass that helps you see a little bit of color changes and depth to look at moles and things like that. Brilliant. Finally, what else makes diagnosis? So observations, and when we say observations, we're sort of meaning vital signs you might have heard in TV shows and movies. So pulse, blood pressure, oxygen saturations, temperature, respiratory rate, how many times you're breathing in a minute. Investigations also, so we talked about history and examination, and then stuff we can do at someone's bedside, so doing these tests, these observations, and then investigations, so ECG, the electrical tracing of the heart, finger glucose, the blood test we talked about, doing bloods, doing imaging like chest x-ray or an MRI, histology, which is sort of taking a sample of a tissue and looking under a microscope. That's often absolutely essential before you diagnose someone with cancer. So if someone has a lump, you really want to be taking a sample of it to get a real, like, this is cancer, this is not, because it's such high stakes, obviously. And then treatment. So, just giving if someone has reflux, there's not really there is a type of test for reflux, but it's incredibly expensive. Not going to do it for the whole population who have reflux. What you can do is just give someone an anti-reflux drug, and if they really obviously get their symptoms better and then they stop it again, the symptoms come back, well, hey, their chest pain, their burning chest pain behind their sternum might just be reflux. Same with asthma. If someone's got a nighttime cough, they've got a cough that's much worse in the winter and in exercise, and they're maybe a bit short of breath in those situations, well, giving them a trial of an inhaler and keeping a diary, that can be useful diagnostic information. So sometimes a trial of treatment can be diagnostic. I think we don't need another round of guess. Well, I'll just tell you. So this is I'm not going to do this. This is boring. Right. I'm think I'm done before we take some questions, because it's been 45 minutes and that's probably enough for people. The only thing, it was just a more, what's this thing? It's a scanner, it's an ECG leads, and I don't want to pull teeth, but yeah, I haven't been able to keep an eye on any chat if there's been stuff coming through there, or if people have any questions.
Oh, yeah, thank you so much for that. It was really interesting, and it was really stretching me as well. I'm sure me and Amma had like a great revision session there. But yeah, thank you. For all the students, like we mentioned earlier, feel free to put whatever questions you have in the Q&A. You literally have a doctor here in front of you, so it's a great opportunity to ask anything that you would like to. I can see someone's got their hand raised. Are we allowed to unmute? Or?
Probably not, just because it's recorded and I put it on YouTube. And the chat is off because of safeguarding. If you do have access to the Q&A tab, so you can put it in there, because then we'll be able to see it. If you don't, put your hand up again, and then I'll troubleshoot that and figure out a way for you to get your question through to us.
Okay, so I can see the Q&A. So would you take into account geographical, environmental history, like where a patient lives? That's a fantastic question. So it's really tricky in medicine. Again, we talked about like the problems in the history of medicine and the way that we there's a thing called biomedical reductionism, which is basically trying to say we can, with just science, we can just put everyone into categories and really predict every single thing, but it's based around biological characteristics that are not actually uniform amongst populations. So the Human Genome Project was really, really interesting in terms of the way people had variations in their genetics. And for example, they found that there was a part of West Africa where two tribes that were sort of a few dozen miles away had greater genetic variation than one of those tribes and someone in, I think it was Sweden or, you know, the Western Hemisphere. And people think, oh, people in these areas, everything will be really tightly genetically linked. So geographical and environmental history, I would definitely take it into account. And obviously, there are certain things like you can take a population and move them from one area and they might have a certain rate of diabetes. And if you see a migration of an entire group to another part of the world where the diet's very different, you might see differences in their likelihood of getting diabetes. But I'd also just really caution people from jumping to conclusions. So a lot of the time in medicine, we go, oh, this person's, you know, South Asian, that's got very high rates of diabetes, therefore this thing that they're presenting with must be diabetes. I think that's really problematic. So I'd definitely take it into account, but I'd also really caution people from jumping to conclusions in these situations. I think that was the only one so far.
Oh no, I can see another question. So someone's asked, what are the most challenging aspects of your job as a doctor?
That's a really interesting question. I think working in a system that is tricky. I don't like it when people say the NHS is broken or it's a broken system. I think that's a really defeatist or like fatalist way of looking at it. I think it's really challenging and really under pressure. And I think if someone comes to me with, say, like a mental health problem for the first time in GP, I want to really give them, like, you know, I'd love to give them a half hour, an hour, but I've got 10 minutes and then I've got another patient coming in. So I think the most challenging aspects is going, what is my ideal level of, you know, consultation and treatment for that person versus what's reality. And I'd have to see 36 people that day. I can't possibly give everyone. So, but then with GP, you have this, the GP in particular, you have this way of going like, right, well, let's talk about it now, and also come see me in a week and let me give you some reading to do about this, and then you can come with specific questions. And maybe for those kind of people, I might be able to then carve out a certain amount of time in my lunch maybe to allow that. But part of that is like, how much can you take on, how much can you take home with you, what's impacting you, you know, mentally. I tend to be someone who's at the more touchy-feely end of the spectrum, I'd say. I've struggled more with not taking stuff home, so I have to work on that. I have to try and compartmentalize a little bit and go like, look, people's problems are really hard and it's really tough to sit through that with everyone, but I need to also function as a person, and so I need to compartmentalize a little bit. So that's one of the most challenging things. Gosh, we've got an absolute flurry of questions.
Loads of questions, yeah. So the next one I can see is, did you ever want to specialize in a specific area of medicine?
Yeah, so when I went to medical school, I thought I liked GP a lot. I like talking to people, and that's like the big tool that you have in GP. And I like the fact it's like a diagnostic puzzle and you don't always have tests to rely on. But for a while, I was thinking about anesthetics, which is the doctors who put people to sleep for operations, but also incredibly sick people. They tend to, because when you're really sick, you can go into a kind of coma temporarily. That means you don't support your own airway, so your trachea, your windpipe can sort of collapse on itself if you're not awake enough, if you're really, really sick. So that ability to put the tube in that you get for operations, and anaesthetists can do that. So I was thinking about that, but then they don't have a huge amount of continuity with their patients, so they treat them and then they go away, and I wasn't a massive fan of that side of it. I think it's an amazing specialty, but I thought about other areas, but for me, I did in my F2, so my second year of being a junior doctor, I did a GP placement and I adored it, and so it was very much the one for me.
Awesome. Essentially, I guess in short, it's just you got to come to medical school and experience the different specialties yourself, right?
Yeah, exactly.
Yeah. The next question I can see is, when you're taking a patient's family history, what do you do about closed adoptions or unknown family?
Yeah, what a great question. very specific, but like really good. What would I do? I mean, part of it is trying to rely on a rapport to make someone feel as though they can talk about that. I don't think I ask everyone, are you adopted? Because there's only so many things you can ask in a 10-minute consultation. But a lot of the time I might say, it's anything around the family. And if they, disclose that to me, then I just have to go, right, well, absolute blank slate. Let's just think about what all the other factors in the picture are that means something's, more or less likely. So it's a downside for those people in the sense that well, maybe sometimes it's an upside, because the family history can sometimes bias us and make us think something else might be going on when it wouldn't be. So I don't think it's the end of the world, but I think the really crucial thing is to have those communication skills and the rapport to be able to have someone feel they can disclose it to me, so I can make the most accurate diagnosis possible, even if that accuracy comes from I'm going to be really broad in the way I approach things.
Yeah, definitely. So I can see two questions that are fairly similar, so I'm going to sort of combine them, if that's okay. So one of them is, what made you want to become a GP? And the other is, what actually inspired you to become a doctor?
So I did. So I found A levels really, really hard, and I was really struggling with them. I got like an E in my chemistry coursework, and so I was going like, oh, okay, medicine. I thought I wanted to do medicine because of scrubs, and then I was like, okay, maybe medicine's not for me because it's hard. And if I'm finding A levels this hard, surely I'll find medicine, harder. So I did biology as a degree first because I just wanted to go to university and enjoy myself and do science as like it's what I enjoy. So I thought maybe that made my career. And then when I was on my biology degree, you have lots of modules you could choose, and then I just kept picking the medical ones. So we had an epidemiology module, we had a cancer module, we had a metabolism module, and I just kept picking the stuff that was medical. And then I did a lab placement and realized that lab medicine wasn't really for me. So then after my year, I worked as a carer, so I was a domiciliary carer, going from house to house, giving people care in their own homes. And that was partly to pay my way for medicine because I couldn't afford to do it otherwise, and I'd have to live at home. But then it also really gave me that feeling of like going and just helping someone, even in really small ways, like just going and moisturizing someone's legs every day to help their skin remain intact and not get ulcers on their legs. And so I got into it because of like scrubs. I was literally like, this sounds cool, but then took a circuitous route because I wasn't super confident, but sort of it was okay to take that time. And in terms of GP, it was really honestly, I think GP is like, if you like GP, it's amazing. It's like the best thing. The only thing is people make mistakes of going into GP because you don't at the moment, although it might change in the future, you don't do nights, you don't do weekends once you're qualified. But that's a terrible reason to do a career, because it's an incredibly long career and people don't, if you don't enjoy it, you don't enjoy it. But if you like a patient, a person, a computer, that kind of environment, and it's about making a connection, it's about your skills as a communicator, unlocking this thing, not just a protocol, not someone's coming in with a myocardial infarction and you're like, let's do the 8 things for heart attack. That's fine, it's exciting the first few times you do it, but I like the art of it. Like, how am I going to make a plan that this person's keen to stick to? How can I make that connection with them and do something that's right for them? That kind of diagnostic artistry and management stuff is the stuff that I really liked in GP.
Yeah, absolutely. And that, I guess that's really reassuring to the students to be able to hear your story and how you didn't take the traditional route into medicine. I can also echo, I absolutely flopped my chemistry mock in year 12. So it's fine if you guys are struggling with that right now. Cool. Okay, so the next question I can see is, would you do a full body exam the first time you meet a patient, or would you have to only examine their area of concern?
Yeah, that's a good question. I think, again, there's a difference between what's the ideal for someone, the ideal like medical practice, if you had like hours, and then there's what's real life. So I would do like a really quick targeted exam. So if they've got chest pain, I'm going to listen to their heart and lungs, but probably not feel their tummy. If they've got tummy pain, I'm probably not going to listen to their heart. So I probably wouldn't do a full body examination anytime. But one interesting thing is there's good data to show that it just touching the other person in a consultation, in any consultation, they go away happier. So if you're just dealing with literally anything about the person, it could be, I don't know, blood pressure. So you're just literally talking about the medicine, just touching them somehow, like, oh, I'm just going to feel your pulse, or I'm just going to take your blood pressure. That human connection can actually make people's experience of a GP consultation a lot better. So I'll always try and, in the nicest way possible, touch someone, but like, you know, professionally make a connection. But I wouldn't do a full body exam the first time I met someone. No.
Fabulous. Next question is, how's the life of a doctor? What are the pros and cons?
Pros and cons. I mean, it's a very seductive life, right? Like if I go to a party and you'll have, you know, you two will have it from being medical students. People go like, "What do you do?" And you go like, "I'm a doctor," and they go, "Ooh." I go, "Yes, ooh, I must be smart," and blah blah blah. But like that's, you know, those are very small things. I think that the pros that people should be thinking about is, do you want to learn for a long time? So do you, like, I mean, really, you know, you're taking exams for 10 years or more from the beginning of your, you know, university. So you have to be happy with learning, happy with exams, like challenges, like you know, being out of your comfort zone at times. But you never wake up thinking, why am I doing this? You never wake up and going like, what am I going to work for? If you work for like a, you know, management consultancy or a bank, that's fine. Like it's great, and absolutely people should do that. But everyone at least some point will go like, oh, I'm, you know, in this capitalist society, you're literally like, I'm here to make someone who's richer than me more money. Like that's generally what people are doing. Whereas if you're doing some kind of health, and it doesn't have to be doctor at all, like, you know, physio, occupational therapist, nursing, clinical specialist, anything you like. If your job is around helping people, then the tough bits, which I don't think we need to go in the tough bits. I think you get enough people being like, don't do medicine. Like anyone who tells you don't do medicine, like let them not do medicine. Like if medicine's right for you, that's great. But the pros are like getting up in the morning and being like, I know I'm going to work. Yeah.
Yeah, absolutely. That's really great advice and really nice to hear as a medical student as well. I can see a question about GCSEs. Just in the interest of time, I'm just going to ask Amma to respond to that question with a comment, if that's okay, and move on to the next one, which is, what if people lie about their family or medical history or hide aspects of it that may be vital to their treatment?
I do want to talk about there's someone asked about work experience, so that's the only other one I'd want to talk about because I want to debug a myth. But if people are lying to me, I feel like it's their business. Like my job is to make myself as accessible and as non-judgmental. So things like we should always ask, do you do any recreational drugs like cocaine, ecstasy, cannabis, rather than say illegal drugs? Because if I say, do you do any illegal drugs, there's inherently this like judgment. People might think I'm going to go to the police. Like widespread people think if you tell a doctor you're doing drugs, they're supposed to tell the police, which is absolutely not the case. So there's huge amounts of me making them feel as though they can trust me with or whatever. But if someone wants to lie to me, like why is it my business whether, you know, it's obviously like I have to just go, look, I'm asking these questions for this reason. This is like, I'm asking about your family history because, you know, it can lead to this. So therefore, you know, but if they lie to me, I think it's very what's called paternalistic, i.e. the doctor's always right to say, silly patient lying to me, like aren't they endangering themselves? I don't like that line of thinking. With the volunteer, so someone said unrelated, but can volunteering in a charity shop be worthwhile for my personal statement? Finding it hard to get healthcare environment. Absolutely, like definitely. Like we obviously, so I interview for Pembroke for the graduate entry program. I can't speak for every single college, but generally we don't want people to just have medical healthcare experience, because otherwise we've just got generations of doctors creating doctors. And if you can find any kind of experience where you are helping people, that should be useful for your personal statement and for your ability to, although personal statements might be going out soon, so be careful, but in your interviews to be able to talk about. So what you want to do is when you're doing any kind of help, whether it's, you know, old person's home, food shelter, religious group near you, whatever you're doing, reflect on what's happening. So what kind of experience have you had? Keep a diary. How has it affected you? And how is that changing your vision of how people suffer or cope with problems day to day? That means it's going to change how you're going to be a doctor. That's the whole point of work experience. But it definitely does, or it definitely shouldn't need to be a healthcare environment. The good thing is if someone cares that it's a healthcare environment, probably not a university or college you want to be going into.
Yes, absolutely. Amma, I'm just aware that it's 7 now. Do you want to stop or continue with the last few questions?
Up to Jack. I'm sure you're busy and you have family life to get to. I don't mind.
I can probably do 5 or 10 more minutes.
Okay, sure. We'll continue doing the next couple of questions. And if you are asking anything like admissions related, Emma will just respond to you in a comment if that's okay. Cool. So the next one is, what skills do you feel are most essential for effectiveness in this field?
Ooh. So this sounds like, not to be presumptuous, this sounds as though you're preempting some of the questions you might get at interview, and I would certainly say checking out the medical sciences page at Oxford has the selection criteria, which talks about the kind of things people look for in medical applicants, and I'd certainly say having a good look at those selection criteria would be a very good place to start. What was the specific, sorry, Nazif?
They said, what skills do you feel are most essential for effectiveness in this field?
I don't like it when people, people might say like resilience because things are tough at the moment, but I think resilience is a skill that you can learn through medical school and something that we should actually be teaching students rather than something that's somehow inherently magically available to people, because otherwise we get this, there's some research done by this person in New Zealand who talks about this myth that we create in all of medicine called the selfless superhuman. So basically, like, doctors and medical students just need to be these like machines that can go through anything, tragedy, long working hours, and not be affected. And her name is Neera Jain, which is Jain. It's a really interesting paper if you like interested in, I mean, it might be a bit much for people, but it talks about the way we perpetuate ableism in society. So the idea that only these selfless superhumans can become doctors, then you never get any disabled doctors or people who might need to take 8 years to do medicine rather than 6 years. And so whereas actually disabled doctors can make incredible doctors because, hey, they've been through the system a lot themselves, right? So I don't like it when people say resilience. I think things like team working is really, really important. I think like communication skills, like we do teach communication skills in specific ways, like how to break bad news, how to deal with someone who's angry. But I think as a baseline, it's quite hard to get people to a higher level in communication skills compared to, say, teaching them about the heart or the lungs. So for me, I think things like that. But then I would say that because I'm a GP, right? Whereas a surgeon would probably be like hand-eye coordination. So I think just take it with a pinch of salt.
Fabulous. Could you briefly describe the process of becoming a GP?
Yeah, absolutely. So becoming a GP, everyone, once they do their medical training, all goes into this giant pool, which is the foundation program. So you do 2 years and you jump around generally 3 things per year, maybe 4 things per year. So either for 3 or 4 months, and you'll do a range of things. So everyone's experienced all kinds of things in the NHS. So it might be surgery, a medical job, psychiatric job, GP, whatever. And then after that, you are able to apply to any kind of specialty program, of which general practice is a specialty, and it's a 3-year program, and you do basically a year more of hospital appointments that are related to GP. So you wouldn't do, say, a really specific cardiothoracic surgery because a GP probably doesn't need to know about that, whereas you might do a specialist palliative care job dealing with people who are end of life, because that's a really big part of being a GP, is helping people die with dignity and in comfort in their own homes as part of GP. So you might do something like a specialist attachment that's relevant to GP, and then you just do lots of GP. So you do a couple of years generally in various GP practices, because they all work quite differently. So you learn how different ways of doing things and that kind of thing, all very, very tightly supervised, really generally really well supported. You have someone called your educational supervisor who you meet at the very beginning of your training, and they're with you every sort of few months. You meet with them throughout your whole training. Your whole last year is under the tutelage of that person. So there's a really nice training program for it.
Nice. So essentially, you'll be like really supported throughout the entire process. So not to worry in that regard. Cool. I like this question. It's very short and snappy. How much do you enjoy your job out of 10? And what do you do when you feel really demotivated or bored?
My job is quite variable, right? So I do a little bit of GP, but most of what I do is education. I love education. Like if I'm doing a teaching session, I'm literally like skipping out of bed. I'm like, la la la, I love this, because I get I'm teaching people to be good doctors and feeling as though I'm, doing something good for the future, but it's not the same intensity of pace of day, responsibility, stress as like a GP day. how much I enjoy GP, I think it depends on how often you do it. So I do it a couple of days a week, and I will therefore enjoy it about 7 or 8 out of 10. I think if I did it 4 or 5 days a week, it would go down to like 3 out of 10, because it would just be very it'd be too much for me personally. Some people can do that, but it's I like but the other good thing about GP is you can have this balance. It very easily allows you to do some things one day and some things another day.
Awesome. So sounds like there's loads of variety, which is great. How does diagnostics change during triage? How should doctors navigate the ethics of prioritizing some patients over others?
Ooh, so this is very protocolized. So someone, if you rock up to A&E and then you see someone jump the queue in front of you, you should be thankful you're not them. You shouldn't be thinking, oh, I wish I was them going in ahead of me, because it means they are much more likely to be sick. So it would be, a lot of the time, triage is really related to those things we called observations. So your blood pressure, your heart rate, your temperature, because there's a reason we call them vital signs. If those are going off in a really obvious way, particularly like you have very low blood pressure, if so say something called sepsis, which is like an infection in the bloodstream, normally from a bacteria that is incredibly dangerous and life-threatening. People tend to have a fever, they tend to have a very fast heart rate and a very low blood pressure, and that low blood pressure might mean they're not getting enough oxygen carried in the blood to all their vital organs, which means they can get organ failure, and that's why it's so dangerous. So that's a huge part. If someone has these vital signs being off, you really like triage that person straight away, and then it's down to headline problems. Is it someone who's had 3 heart attacks before presenting again with chest pain? They probably need to be moved through. So it's partly someone does like a really tiny history, take someone, observations, and then triage is based around that.
So we've got a nice little thank you comment as well in the chat from one of the students. And I think this is the last question, because the one that comes up later is about the BMAT. So this is just how and what made you realize medicine was for you? So essentially, what were the things that inspired you to study medicine?
Yeah, I mean, genuinely Scrubs was a thing. I thought it handled a lot of the material quite well at times, even though it was silly at other times. But I thought it covered some really nice topics like dying and loneliness and chronic disease reasonably well. Inspiration, like that was, and then some of the professors I had at my undergraduate degree. So there was someone who I learned about immunology as this biology degree, and there was a professor who had multiple sclerosis, which is a disease where your immune system gets confused and attacks your own nervous system, and so you get a progressive problem with your nerves. And he walked with crutches at the time, and he brought in his own scans to show us. So he put his scans up on the screen and said, this is me. And it was just an incredibly powerful thing to share with us. It made me feel really privileged, and it kind of gave me that taste of when a patient shares something with you that's really privileged. So that was quite inspiring.
Yeah, absolutely. That sounds really, really interesting. Having a patient present things to you must have been a really different experience. Sorry, I know I said that was the last question, but I can see some more students have asked. So we've got, how do you balance your social life and work life, since medicine is always filled with a lot of work?
Yeah, I think how do you do that? It is tough. I think a lot of what you're doing, especially, let's talk about being a student, I think that a really crucial skill is conscious relaxation. So you never, especially when during being a student, you always an exam on the horizon, right? And so this element of, if you're not doing something, you're like, I should be revising, like I wish I was doing that. Either like working or relaxing and allowing yourself, people think, and it'll be true for all of you with all your exams, people think there's this like graph of, let's say, y-axis, x-axis is work, like how much work you're doing, and y-axis is exam performance, and people think it will be just this line of like, the more work I do, the better I'll do. And that's just not the way humans work. Like you will hit a law of diminishing returns, or you get up to a level, then you do more work, and actually you're so tired and you can't take stuff in that you'll start to drop in your performance. So an element of going like genuine rest. I never did revision for more than 2 hours at a time, with at least a 10-minute or half-hour break for me personally. Everyone's different, but I think a huge part of being a doctor or a medical student is being mindful of like, now I'm relaxing and I'm allowed to relax because I'm a human being, and actually that will help me be a better student, performer in my exams, doctor, or whatever.
Yeah, amazing. Well, yeah, thank you, Dr. Jack, for your time. That is all of the questions, finally. Just a last note from all the students. Emma's been posting the feedback form in the chat, so if you guys could fill that out, that would be great. We are having more sessions like these, so these are part of our monthly seminar series, so just keep an eye out on like our website or our social media to be able to sign up for more of those. Emma, do you have any last points you'd like to add?
No last points, but just thank you again, Jack, for the talk. It was really enjoyable. Like Nazifa said, it was very good. Practice, and tomorrow when I go into placement, I'll make sure I keep it all in mind.
Nice, I love it. Well, thank you both so much for making it very easy for me. And yeah, I'd be very happy to give another. I've got one on pharmacology like in the bank ready to go that I do for other outreach stuff. So more than happy to come back. But thank you both for making this very simple from technology wise for me.
Of course.
And for help and for answering all my questions as well. You did so good. It's nice to have the back and forth. So
Cool. Yeah, you know, there was that one question about the bruising on the finger, and then after you asked it, I was like, oh, I know that because I test my blood a lot as well.
Right.
So I should have known that. But
oh no, but come on, it's fine. It's not a problem.
yeah, it's fine. It's okay, guys. Medical students aren't perfect, even regardless of what, media tells you. Cool.
Absolutely.
Okay, you're all free to leave now. Thank you very much for tuning in.
Thank you everyone for your attention and time.